So, what do chemistry, ion exchange, and fuel cells have in common? Well, Esther Halton spent 30 years, sorry about that, Esther, doing research that covered those topics. She is currently an instructor and researcher and mentor at University of Calgary's Patient and Community Engagement Research, the PACER program in Calgary. I can't do better than simply read the title of her presentation, which is Why Listen to Patients and What Do They Know Anyway? I think Jeremy might have something to say about that. Esther will be tag teaming with Deborah Marshall. Deborah is a Canada Research Chair at the University of Calgary. She's the co-lead of the patient engagement theme of the Imagine Network, a SPORE network. It's a research network whose overarching objective is to study the interactions between inflammation, microbiome, diet, and mental health. And that might sound like it's something to do with cystic fibrosis, but this is actually in looking at those interactions in patients with inflammatory bowel disease and irritable bowel syndrome. She's incorporating patient-oriented research and patient preferences. She also studies risk-reward evaluations by patients in terms of their choices, patient choice. How do they make those choices? She'll be talking today about listening to patients. Without further ado, Esther.
Clicker. So we're going to start with one of our research students. Go ahead, Jim. It's ready to go? Or right now is good. Yeah.
People will talk more openly, maybe, if they're talking to another patient than if they're talking to a professional who really has a certain amount of important role to play in their recovery and how things go. My name is Jean Miller, and I am a PACER lead researcher in the Patient and Community Engagement Research Program at the University of Calgary. And I was fortunate enough to be in the initial student group where CIHR funded a project to see if patients could actually engage other patients in research. I signed up for the program because I heard that it was focusing on osteoarthritis. And I had just found out I had osteoarthritis in my knees. So I came to the classes and found out that there are other people who not just experience the pain, but are dealing with some of the things that happen as your knees have arthritis and get worse. And we discovered a common interest, and that led us to our student research and on into other projects, and it's been an extremely rewarding experience. I'm a nurse by background, and I taught nursing and have been involved in nursing research over the years. It was hard to leave the nursing lens behind and take a patient lens. But once I got through the program and saw what Nancy was trying to get through to us, it really became exciting, and I began to see how the two types of research are in some ways similar, but mostly different. So nurses can study patients' experience, let's say with pain, after a certain kind of surgery, and generate this body of knowledge about how best to care for people after they've had an operation, relation to their medication administration and things. Patients, in PACER, we also study patient experience. So that's a similarity, but probably that's it. When we study patient experience, we are doing it as a patient ourselves. So I engage other patients, not as a professional nurse, but as a patient in studying experience. After 5 years, I sometimes wonder, as years go by, why do I keep doing this? But the reason is because we work in a healthcare system and a university environment where the patient voice is taken very seriously and where patients actually are having an impact. We as patients don't design the healthcare system, would be in trouble if we did. But our voice is taken seriously, and it's just so exciting to work in collaboration with them.
So PACER started back in 2012. Sort of patient engagement research really started in about 2005 out of England. Deborah was one of the 3 starters of this program, which was around arthritis. And at the same time, Alberta has about a population of about 5 million, and they started the 6 SCNs. And the idea of the SCNs were, how can we improve deliverables and have better outcomes for everyone involved in the system? A lot of the patients started as part of the advocacy groups, and what we were listening to and wanting to hear was patients' own stories, but not as an individual patient. What you get with this type of research is you get saturation, where you hear the same story over and over from a population, so that story of one is repeated by numerous people. And patients are now, a lot of the people that are taking the course are also working in bigger areas. SPORE started in 2014, focusing on patients, caregivers, families, and how they could ultimately lead to outcomes. And just as an aside, what we learned doing our research is that you have to break these groups out separately. So if you're doing research with children and parent caregivers, you don't have the children talk with their family there. Or if you're working with partners, husband and wife, or some sort of caregivers, you'll get really good stories that are important, but you don't put the caregivers and the patients as well as they like each other together, because you don't get the same outcomes and people don't feel free to speak. Most research we're starting to see around the world, not just in Canada, they're requiring a portion of research to be part of patient engagement. And the big reason we're seeing this is that you can start to see, you don't sometimes get a full picture, or even in some of the pharmaceutical studies, you'll find that a pharmaceutical might falsely look like it didn't work, but it might work to the sense of the patient feels it works good enough, but not the theoretical. Like, you might have an expectation that we want this level of coming back, but the patient might be just happy with this level. And one of the studies I looked at out of Europe, they have sort of 60 subjects they look at, like general topics for theories, and they put a bunch of doctors together who were on transplant teams and a bunch of transplant recipients, and they said, what are the top 10 things that are most important to you? The physicians named 1 to 10, and their number 1 was the patient's number 10. Now, the patient's number 1 was not even on the physician's list, what they considered the most important thing. So sometimes physicians are trying to do their best, but they don't actually know what the patients really want. Our patient program has now built, so it used to be a course taught at U of C in person. It was, it's about 18 months. It was 5 hours once a week and once a month on the week, one Saturday. Now it's an online course, and we have people all across Canada. We're doing some of our stuff online, like even our focus groups, and it's becoming quite quite advanced and quite interesting, but we are starting to find some of the problems of being online. We're working around it. It's working great, but it's a whole different process online. Oh, I already talked about that. So basically, PACER, you start off, you take the course, you become a teacher, you work, mentors and students work together. So the course is actually, as a background, I had never taken anything where there was so much hands-on of people above you taking care of you. Like even when you're in your master's and you were working on those projects, you don't have, I was like, I can't believe all the people that are helping you out. So it's a very tightly organized. It's also a group project work. So you take on the roles of taking the course, becoming a researcher, you slowly become an advocate, a consultant. Then there's more training to become a mentor, an instructor. So because there's such a hands-on thing, each team has their own mentor. I presently am mentoring 3 teams right now. And then you work in research or special projects, and then you become a full-fledged research project. So the roles that you have is you sort of start off as I'm a patient, and to tell you the diversity of students we have, over the years we've had 2 physicians, a lot of nurses, and actually as a group, nurses have probably the most difficult time taking the patient's view. I had a student recently who, very intelligent, but she did not finish junior high. She went to residential school, and as part of her protest, she can read a lot, but she does not write. So somebody else was writing for her. Some of my cohorts right now, and some of the students I have right now, I have one that she does cancer research with children, and she has 4 degrees. And we've got 3 of my students are science students planning to go into research, but they just want to learn about the human voice. So the range of students we have is huge. But I think part of what you want in a student is you want the openness to be able to listen to other people and not tell people what they need to do. People who have been unsuccessful, surprisingly, have often been people that can't work in groups, who know best what the patient should be doing. If you take something like John Nash's game theory, you find that the diversity and the more people you get in, the greater the knowledge that comes out. So it's really important to work in a group, and that is surprisingly one of the most difficult things, and the people that we have asked to leave the course have all been people that cannot work in the group. They may be very educated and do great, but they cannot let somebody else, they can't work as a group person. So it's quite interesting. And then we continue on training, become a teacher, and work on through. Oh, I've not showed you the slides, but let me go. Here's a beautiful slide. So, sorry. It was on my screen. So, patients as peer researchers, the impact of the role of the patient. So we're an independent group, so we often get hired for the front of a project, the back of the project, or throughout the project, or we might just be hired for little bits and pieces. And we work with a whole range of groups. What you find is the patients feel very safe. Even though you have a very good relationship with your physician or your whatever caregiver you're dealing with, there's still an imbalance of power, and certain things aren't shared. I was telling somebody just recently, we did a study on mental health where some stuff was revealed that was nobody sort of would expect to see, and it was basically you feel safe, and other patients will confirm, oh yeah, I've had that too, and that's how the information. The focus groups are very long; they're like 5 hours, and we're looking at new ways of finding and getting peer-to-peer research. So I already covered that. All right. Oops. Sorry. So how this works is they've broken PACER into a model where we're training patients in this research method, and we also do data analysis and validation of information and the impact of the quality of how we can improve the healthcare services. The program depends on training students and increasing the capacity. And our big objectives are getting our theories, salutogenesis, which, if you don't know what it is basically focusing on the health of a patient versus the disease of a patient. Although they're both interacted, it's how you can make somebody's life better through whatever means that is. Patient engagement, and it's all qualitative research. And qualitative research, given my background, I found very difficult to do initially. I'm now a believer. I've drank in the Kool-Aid. But the N numbers are very small, but they are you can reproduce the results, but you reach saturation. But when I worked in chemistry and ion exchange, our N numbers were numbers of 10,000. So finding these small numbers initially when I first started doing this was very uncomfortable for me. We do co-design, and co-design is working with patients to help figure out the question. And sometimes we find that our sponsors, so of course we're going to answer the question they want, but it's sometimes you have to go around how the patients want to hear about it. So they'll hear what you're doing, and they sometimes panic because that's like not exactly what they want to hear, but we will direct them, but it often comes out. I mean, I just did a study with First Nations or Paddle Prairie Métis community on cancer, and it was sponsored by, they wanted to look at screening, but they didn't exactly want to look at screening, and they came up with a different question. The sponsors weren't that happy, and they came out with the results. The results are fantastic, but basically the results come out with why aren't people getting screened, or why aren't doctors getting screened? Because what we're finding in this community, virtually 90% of the patients are diagnosed at stage 4, having typically been going to physicians, this is Northern Alberta, for at least 10 years and complaining about things. So they got the results they wanted of screening, but that wasn't the initial question. We carry out a variety of different components that we can do for people. And Jim, oops, I forgot to push the thing again. You'd think I'd never talked before. This is Sandra's story.
When you truly listen to a patient's experience and their journey, you really do start to get a different direction on what's important, and not necessarily what people think is important, but what's important from the patient perspective. So my name is Sandra. I originally heard about the PACER program through my volunteer work with Alberta Health Services. I sit on the South Health Campus Citizen Advisory Team, and we received some information on PACER. And as our work progressed with our focus group and the individuals that we worked with, I soon discovered that I also could be a participant in that group because I was a patient. And it was quite eye-opening to hear individuals talk about their experience with health and saying in my head, oh, I've done that. Well, I've been there. I've seen that person, to discover that I too am a patient with chronic health issues. And it's a very different awakening to realize that I had a voice. I'm not very shy, and I love advocating for patients to speak up. So it was a perfect fit. So through our research in participating in the PACER course, I soon discovered that a lot of the things we thought we would learn or we thought we wanted to know, in fact, were not the things that patients wanted us to know. And so the questions we thought we wanted to ask were, in fact, not the questions that we needed to hear. And when I did the PACER program, I was re-motivated that maybe my impact in this world would be better served in health. And I ended up getting a position with Calgary Foothills Primary Care Network. The messages, I guess, that I regularly want to bring is, where is the patient voice? Do we have a patient involved when we're making decisions, or what programs or services we need to offer? And I think we need to change the thought process on how we develop that, because when we work in health, we forget about a patient's view is very different than a person who is in health all the time's view. And I'm only working part-time, and I am still an active volunteer, constantly promoting that patient voice and what the patient can bring to the table in improving healthcare, which is my ultimate goal. I hope that my contribution will improve healthcare and ultimately improve people's health overall. And so it's been a wonderful tie-in. And between my volunteer work and my paid employment work, I get to do some of those things. So it's an awesome way to continue to sort of spread that patient voice, that patient message.
So one of the things that you really have to look at is the insider and the outsider's knowledge base. So as a patient, you're an insider. Sometimes some of our patients, researchers, they are patients, but it's a totally different area. And so you bring in your knowledge, but you don't necessarily want to bring in your advocacy. And we also are really good at PACER at working with groups that are really hard to reach, that often don't get a voice out there. And we've been pretty successful in that area, and so sometimes people are coming to us. Also, sometimes we work with the group, but we get answers that a group wouldn't typically see. I remember to click. So the benefits is basically getting the inside voice and inside knowledge and all the potential benefits that come with this. So you're much easier to rapidly engage. There's not this power dynamics that even if you try to not have it, it's going to be there. And you get a much deeper understanding of people when they're telling their story, and they can tell their truth without having judgment or worry that the impact of telling what's happening can have an effect on their health care from the physician or the caregiver. PACER is a 3-step framework. So we start with what we call a co-design, which is a sort of a set where we come together and we ask people in the area, what should we be studying? We often frame it in a certain area, but we basically run a really large focus group, and then we bring them back and at the same time, and we look at sub-themes and themes and come up with a question. Then we go to the Collect, which is where we do focus groups and individual interviews. And that's where we get emerging themes that we come up with. And then we come up with what we think we've heard, the major themes, how it works, and then we bring all of our data, group it down maybe to 4 or 5 general things, and we bring everybody who's been in the earlier groups, we invite them to come in and we say, okay, did we get it right? And we spend another day of them talking about what worked, what didn't work. That we kind of cover all of that. Our data is interpreted from the patient's perspective, and that's where you've really got to make sure that bias doesn't come in. It can have quite an effect if you do, so you have to kind of check yourself. You provide the research with the information that can help improve the services. And some of these improvements can seem like quite small, but can have a pretty big major impact. We're on phase 1 of a 3-phase right now with mental health of youth 8 to 25 who enter the emergency department. And we provided a group of 250 physicians and nurses in the emergency department in Alberta a day, and we talked about some of the stuff we were finding. And first, on one of the roundtables, a lot of physicians were very uncomfortable with what they heard, and they did not want to hear it, and they were like, that couldn't be happening at our hospital. But what they did do is they made some really small, significant changes. They didn't separate the children. If you try to commit suicide in Alberta and your parent is separated, they lose custody for 24 hours. Well, you can still lose custody, but stay with your child. They don't require them, when they come into the hospital, to take off their clothes and put on gowns. They want to feel comfortable. They want to feel natural. They allowed them to have pens and paper. It was very small but significant things that is having an impact. Listening to the family, listening to the child saying, I want my parent here, I don't want my parent here. But there was a status that we don't have the parent there. And so it was significant, and we're just at the very beginning, but even those small changes have made quite a bit of a change. Strategic use. So the patient research facilities, the groups interviewing patients and analyzing the data, this is kind of like, is this result trustworthy? Because, as I said, as a background in big numbers, I was initially secretly not telling it with anybody, but I biases. And some of these research have shown that it's reproducible, and it does have, it has validity. We use research categories, academic supervisors, and we employ questioning, and we complete literature researches of all of our findings to see what's out there and some of the similar things. What we find a lot of times is that the questions we're asking are not really answered out there. So here's some of the examples. So here's the one I was talking about, this study that I'm doing with the youth visiting the ED. Now what is interesting about this is that we did a preliminary set design. We typically only do 1, but we did 3. So we did 1 with youth, and then we did 2 with parents. And the youth were fantastic. They were like, oh, there's going to be a questionnaire. Can we see the questionnaire? And we're like, well, Alberta Health doesn't really want to share it with us, but yeah, okay. So we gave them the questionnaire, and they're like, nope, nope, nope. Don't send it out by email. Don't let my parents see what I'm going to see. They changed all the questions. Now, what was significant about this, we brought it back to Alberta Health, and they said, you can't ask open-ended questions in a survey. You can't do this. And these were, but they decided to put out basically what the students had done and how to reach them. And typically, Alberta Health, for these surveys, which they do all the time, get about 100. Well, they got close to 2,000 responses. So they were like, oh, maybe we're doing something. And we're not talking just youth and adults. So it was very good. Some of the other studies we've done is stillborn children, and basically how healthcare can help them, and understanding that. And then another one that I was involved is after the crisis, which is basically people were talking about, we started asking them what happened before you had a mental health issue, and they all came up with basically the same cycle, although the cycle might take a month, or for some people might take 15 years, but it's essentially the same cycle we see in everyone who's struggling with a mental health issue. Oh gosh, I don't normally do this, I'm so sorry. I think it's because the importance of reflection in PACER research. So you need to increase the focus on the self-knowledge and sensitivity to better understand the role. PACERs continuing aware of their position of the insider and the outsider and the continuum, because you can be a patient, but maybe you're totally well and the majority aren't. So you've got to keep this into consideration when you're working to listen to the whole range. And the goal, of course, is to collect participants' experience through and then analyze the comparisons. We have, everything is taped. And one of our studies, which was critical care, studied the analysis. So we did a study on critical care, and then we sent it to an Alberta Health Service provider, quantitative research, to see what their results were. And both teams came up with the same similar themes, but their conclusions were totally different. The researchers basically heard that what patients really wanted was better parking and better waiting rooms. But what PACER identified was that families felt like broken, and they didn't trust what was going on, and they felt like it was breaking the whole family apart. So although they heard the same thing, they didn't get into we did the reflect, the other group just listened to the analysis, so we got all the feedback, but we focused on what we heard, which was the breaking down of families in this very difficult time. The recognition of the values. This is some of the researchers who have used us and the clinicians. Some of their voices have said, now that we have been bringing PACER into projects early, through the co-design is where we should begin to engage patients. So that's right from the start. I would now find it difficult to work and not have PACER in the room. I would be a real missed piece, and other people who haven't experienced that, they don't know what they're missing. And patients and families, members lead research in a novel research approach that is flexible and can be used to identify opportunities to improve care. And where PACER is today. So basically, the demand for patient research is increasing. A large number of funding groups require some patient engagement, and I have been at conferences that are supposed to be patient engagement where the opening speaker has started with, okay, we have to use patient engagement to get the funding, but really, what do patients really know? Which is a bit shocking, but there is starting to be a change. But if you've been doing research for years, sometimes it can be difficult to hear other voices. And we've done a range of programs. So we've done arthritis, bladder cancer, heart, post-op, malnutrition, Indigenous communities, mental health, a large number of mental health, chronic pain with medical marijuana, quite a bit. And now we get to hear Marlon.
I did not want to give up because then people would think I was old. Arthritis is not an old person's disease. I was waiting for a hip replacement surgery, and I had waited in line for 8 months. I'd had my x-rays done, everything done, just waiting to be called. So I went in, 8 months, saw a specialist who immediately looked at me and said, "I'm sorry, I can't do your surgery. You will have to go to a specialist." So thinking, well, specialist. So when we went outside and he booked me in for another 4-month wait to be able to see a specialist. So I was really annoyed. By the time I got home, in fact, I was really furious. So I went online and tried to find something like an ombudsman, somewhere I could complain, somewhere where I could say, hey, you know, get the line right at least. So I saw this site, it said patients matter, and that kind of hit me. I said, you're darn right, patients do matter. So I clicked on the site and found, to my amazement, it was not a complaint site, but it was an invitation for people who had osteoarthritis, which of course I have, to join a pilot project that was being funded federally right across Canada. And the project was in Alberta to try to teach patients to do research with other patients. Well, I'd done a bit of research when I was doing my master's degree, some qualitative research. And so I thought, that would be really interesting. So phoned him. 1 week later, I was in class. So that's how I joined. The wrong way, probably.
Next slide. So the niche that patient-led research, you're building new relationships in the model of engagement, quality of life research, the emphasis of talking and getting opposite roles is difficult to locate, and where the power dynamics exists. In practice, peer-to-peer research has given patients pathways to take on roles of leadership and make a real impact on changing healthcare services. So there's our beautiful 3 sisters, and thank you very much. Why don't we have Deb speak first, and then we'll do questions at the end together.
All right. Getting the baton. Okay. All right. So does anybody need to get up and stretch? I just came from an osteoarthritis conference. It's very important to keep your muscles moving, you know, keep the blood flow. No? Okay. Please do if you want to. But I'm Debra Marshall. I'm a researcher, and I must say I was chuckling because Jean and Marlon were in our first cohorts when we did PACER, and it's so Jean and Marlon watching their videos. So that was kind of fun. But what I would like to do, and first of all, I must say thank you for the invitation to come here. I'm very excited that you're having a whole day and a half dedicated to talking about patient engagement. As you can tell, in Alberta, we take it pretty seriously. And there's lots of other models. It may not be the right model, but we're trying to figure out ways to seriously engage patients. And really interested to learn from your experiences as well. So what I want to do in this time, and I'll try to be quick because I think we want to have discussion,
is talk about, I'm going to call it many faces of patient engagement, because this is a really used and misused term these days, and it's a little confusing sometimes. So I'll flip through that very quickly, and then give you a couple examples, and then also talk about, I guess, my own views on successes, challenges, and myths around patient engagement. And use also the SPORE Imagine example in this. So I think this is fundamentally why we need to talk to patients. In the end, we know, the one thing we do know is that patient values aren't system values. Even though I'm a health services researcher and a health economist, quite frankly, I think we need to completely blow up healthcare systems because they are not designed around patients, and I know we talk about that, but it's just wrong. And I think our whole world is going to change soon, and actually, patients can help us do that. So I think it's very important. So patients, well, they actually are the experts because they're experiencing it. So that's why. Because it's right. I mean, some people, and I think maybe this sounds a bit too strong, but morally, at some point, I'm a taxpayer. When I'm a patient, I want those services to serve my needs. And we have lots of different needs. So I think we really, really need to do this in a serious way. And it's relevant. We want to measure what's meaningful. Sadly, and even though I'm a researcher, and some of my researcher friends aren't very happy when I say this, so if there's any researcher friends out there, don't beat me up. But actually, a lot of our instruments are just wrong. You know, we spent a lot of time measuring what we call psychometric properties, which are important, but at the same time, the questions are wrong sometimes, like they're just wrong. And I actually think we need to blow up a lot of our health reported outcome measures too, and start all over again. But that's why we need people to rethink of this. And then also, I think we can make a difference this way. And we do have examples now in Alberta where sometimes really simple things that basically cost nothing can be changed, and it matters. So yeah, we need to get patients in there. I'm going to give you 3 or 4 or 5 examples. You can't read the details of this, and that's fine because you don't need to. There's lots of different models of engagement. So when you're talking about engagement in your community, think about what it is you're trying to do and look at all these different models. So this was a systematic review done a few years ago now, which looked at different methods of patient engagement. And in this review, there were 19 different models that were identified. And the key problem there is that the literature right now is a whole mess because people use the terms in different ways and they mean different things. So as you're thinking about engagement, please think about what it is you're trying to do and how you want to set it up to make it do what you want it to do. And this one was also a review that was commissioned by PCORI, which I think you're hearing from Lisa Stewart later in the program, so she'll talk about PCORI, so I won't tell much about them here. But here, this review basically said, look, there's lots of different ways you can engage patients, so this goes across the whole research spectrum, and there's examples in the literature of where patients are being engaged or not. A lot of them are at the front end or at the back end, but not as much in the middle of the research process. And with PACER, what we tried to do is involve people throughout. Very importantly at the beginning, even before we get that research question. In fact, several of my studies have been blown up because they changed the research question on me, and it's really hard to write grants that don't have a research question in them. But nonetheless, we got really useful information out of it. But one of the other things around here is, yeah, we can engage people in lots of different settings, but also have to be realistic. Because patient engagement, while obviously I'm a fan, as one of the founding people of PACER, it comes at a cost. It takes time, it takes resources, and the real potential risk, I think, is that it's tokenistic. Don't do patient engagement because you think like everybody else is doing it. So we should do it. No, think about what you want from it and what's going to be meaningful, and let's not do the rest. And actually, that's why PACER was created. So this is another model that you might have seen. This is the Karman Model. And what it tries to do is lays out, and I'm happy to share these and give you the references, but I just want you to be aware of all these different things. It's a nice framework that says the more engaged we have people at different levels, the more implications and the more impact they can have. But this also speaks to the idea of tokenism, because if people aren't heavily engaged, then you probably won't get the impact you may or may not be desiring. And it doesn't mean that it's bad, but there are different roles and different levels in which you can be engaged, and you should expect different outcomes from that. So think again about how to plan this. And this is my favorite because I'm a health economist, and that is from Hibbard. They've done a lot of nice work, but this was published a few years back, which basically developed what's called a patient activation score. Okay, that sounds very nice, but think about it, activated patients. Well, what they showed is that people who are activated, and they actually have a PAM score, patient activation measure, people who are activated in their health have better outcomes, okay? So what they were able to show is that they actually had, for every 10 points on the PAM score, they saw a decrease in emergency room visits of 1%. And this was a large population of people in the US, okay? Well, that's good news. Policymakers want to know that. And I think this is the kind of evidence we need to be bringing to bear to say that, you know, patient input matters. And then the second one, again, my favorite, people who are less activated cost more to the health system. Well, healthcare payers are going to want to know that too. So these are the kinds of data and information that we can use to show why it makes a difference. And this is then leading into PACER. These are the old slides because I'm from the old era, but this is the set, collect, reflect that Esther talked about in the collaborative framework. And the reason why we did PACER is because we didn't want people to be token patients on committees. And our strategic clinical networks wanted the patient voice on these networks who were meant and mandated to improve care and also think about new ways to do things. And so they needed people to have a way to have a voice at the table sitting amongst surgeons, healthcare providers, administrators, senior people. I mean, Jean Miller, who you saw in that first video, knows the Minister of Health, okay? Like, she's met with him more than I've met with them, or probably anybody's met with him, because she had his ear when we were doing this work. She was at the table, and she was able to start affecting change. Salutogenesis was mentioned. The whole idea and the foundation, the theory upon which PACER is based, is being able and motivated to handle your health. How do you be a doer? You heard each of those testimonials. These people are doers, and they're not just talking about themselves, they're talking about how do we change the system. Of course, they can't do it alone, but they're working with the right people to make those changes, and they're part of a team. And the key finding from this research early on in PACER was that we built new roles, and we changed the culture around the table. That's ultimately what we did. We changed the culture of how we do things in Alberta Health Systems services. So arthritis is where we started. This is just an example of what we did, and Jean was involved in this. This was the first study for me as a researcher where I had written PACER into the grant. So we had done our initial grant, and we developed this program, and we wrote PACER into the grant, and we got funded. So Jean was my co-investigator. It changed everything. She wasn't somebody I was studying. She was part of my research team, and we were studying the problem together. And this was monumental in certainly for me as a journey, this has been the most interesting journey I've had in changing the way I think about research. So the idea was here to look at arthritis and models of care. And how do you define quality of care? What is quality of care? So Jean, you will notice the publication here. Jean Miller is the first author on this paper, not me. My grant, but Jean was the lead author on this paper. So this is published, and this is the model they came up with. And it wasn't about hip and knee replacement wait times, actually, like Marlon talked about, but they said, this is a chronic long-term disease, and I think that very much relates to cystic fibrosis, chronic long-term disease. We need to know the right information, we need to have the resources and the supports, and we need the right relationships with our care providers as a team. And we need to know how to manage, because this is a chronic disease in my body, and it's not about a surgery. That's just a moment in time. I need to figure out over my lifetime, how am I going to cope? Okay, so that's really what they came up with. And they said, this comprehensive information, they want a personalized self-management plan, they want a collaborative relationship and better access. And what's happened as a consequence of this in Alberta Health Services is our shift has actually moved towards what we call conservative or medical management of patients in osteoarthritis, and this is now the priority for the strategic clinical network, is to figure out how to do this better. So they have set the agenda. So these are, our recruitment, sort of, and there's one of my other colleagues, Sandra Zelensky, and this leads into IMAGINE, because this is around inflammatory bowel disease. And IMAGINE actually does stand for inflammation, microbiome, alimentation, gastrointestinal, and neuropsychiatric effects, and I think all of you would agree IMAGINE is a much better thing to use, because even I can't remember that, and it's been a little bit now. So this is a SPORE-funded initiative, so we also have patient and community engagement research in this. This was background work that Sandra was involved in at our clinics in Foothills, which I think was part of the reason why we also had this in IMAGINE when we did this grant. And what they did was map out what is it like to live with IBD. And they talked about this emotional and physical pendulum. And we're able to draw, just like this lady, so I've been watching them back here, it's kind of interesting. Are you translating my key points right? Yeah, got it? Okay. Am I allowed to draw afterwards in case there's anything that I forgot to say? Excellent. We'll do some post hoc modifications. Of course, I can't draw, but nonetheless, they were able to draw out what was this journey like. And I particularly like this one on the right, and I know you can't read the details, but what they describe this is the roller coaster. So I have to live with this disease, and there's this whole almost grieving process of understanding what it is, learning how to cope, regressing, getting worse, getting better, and it's this roller coaster process that they have to go through. So this was helpful in trying to picture and understand how we have to manage better. And then this was the family members, and I find it quite fascinating that the family members had a very structured step picture versus the patient, which was ziggy-zaggy roller coaster. So what does that tell us? How do we have to engage families and patients differently or together to try and manage and cope with this disease, and what do we need to provide as supports? So their key findings were we need to have a holistic view of patients, we need peer support, we need education, we need coaching, and they actually made recommendations to the IBD unit and said, we need a centralized unit. We need to make sure we aren't being missed when we're having issues, and there needs to be coordination of this. And actually, Remo, Dr. Paccioni, who's the head of that department, changed how they do IBD care delivery. Where are we today in IMAGINE? So this is a SPORE network grant. It's across Canada. It's a fairly large grant, and it's focused on the microbiome, actually, and inflammatory bowel disease. It's one of the 5 SPOREs. These are the activities we're working with in patient engagement, so developing capacity, supporting and implementing research, looking at aspects in treatment of care, and setting new research priorities. So these are the 4 components of patient engagement. And my favorite, and it was mentioned, thank you, at the beginning, is around patient preferences. And when I say patient preferences, what I mean is specifically, how do people make risk-benefit trade-offs in treatment decisions? And a really interesting question right now is this hot topic of fecal transplant. And when I say fecal transplant, I'm looking at the faces. Some people go, oh, that sounds good. That sounds very natural. I'll get some new poop and maybe things will be fixed. Well, some people go, ew. You know, there's kind of two groups of people. Well, what we're trying to do is understand and learn from patients, you know, what is it that's beneficial and what do they see as the good things about fecal microtransplant, and what are the potential risks, and then how do they trade them? What risks are they willing to take to try these new treatments so that people understand the implications, because we still don't quite know everything we need to know about it yet. It's early days. So this is a study that we're just about to launch. It's in ulcerative colitis, and we're looking at preferences and looking at these alternatives in FMT. And one of the things I learned in this process is that capsules sound okay, you know, when you say, oh, well, you can take it orally, you know, no problem. Well, it turns out you have to have something like 100 capsules, and, you know, you wonder if they're not at the right temperature, they might break, and these sorts of things. And, you know, it's a little more complicated than that. So what we're trying to do is understand what is the best way to deliver this care and who do we offer it for. So this is the kind of research we do, and it was mentioned at the beginning that you have an interesting risk-benefit challenge as well, because unfortunately there can't be a lot of patients here at this meeting, because I understand there are some risks of transmission and disease. Well, but that creates a really logistic problem, and there are also some maybe harms. I don't know if I want to call them harms, but there's certainly disadvantages to not having people here sharing in the room with you. So that's an interesting risk-benefit question that maybe needs to be addressed and could be used. You work with patients to figure out what are those risks and what risks are they willing to take in order to have the benefits that might be had from either being in this kind of room or going and getting different treatments or sharing their stories with other patients. So that's an interesting question. So this is what they look like when we do this. We have all the different characteristics to consider. So, you know, in this case, what's the chance of remission? What is the chance of having an adverse event? How do you have to prepare and do this? And we ask people to make choices between one and another alternative. And that's how we quantitatively learn what's most important. So in the end, I can say people are willing to accept, you know, a 1% increase in risk of an adverse side effect if they can get a 10% increase in the chance of remission. So those are the kind of statements I can make from that. The second is capacity building. So we actually have 2 cohorts of pacers being trained because we think this is an important capacity building activity for our network, and we are working with this process, the new PACER process, where we have a 3-stepped course, and we are doing this distance now. So this is new for us, because we used to only be able to do this in Alberta. So we've done the first stage, and our trainees are now in stage 2, where they're doing their practicum, and then they will actually do a research project. And as Esther mentioned, at the University of Calgary, we have a certificate now for people who graduate, and it's recognized by the university in patient engagement research. And then they're also, they meaning the PACERs involved in Imagine, are also doing their own engagement projects, and the focus right now is on recruitment and retention. Because Imagine is a large study. There's 8,000 patients being recruited across Canada, and retention, because it requires quite a bit of sample, blood samples, stool samples, repeatedly, it's hard to retain people in this study, and it's a long-term study. So our patients are helping us figure out how can we retain patients in our study, and what are the issues. And so they actually developed this recruitment figure. I don't know, but if anybody is interested in joining the Imagine study and has poop, you're welcome. We want yours, so please do. But they're engaged in figuring these things out. So just to close, I would like to just give you my reflections on successes, challenges, and myths around patient engagement research. I am convinced it is possible to engage patients as truly a member of the team. I think we can change healthcare with patient voices, and I would also say as a taxpayer, all of us will eventually be patients, so that means everybody is eligible to be part of this initiative, and I think we need to figure out what we want when we get into the healthcare system. It's really hard to overcome traditional perspectives. We've done things a certain way for a long time, and people might go, oh yeah, that's great, but they don't really mean that's great. And we've certainly had some interesting challenges from other healthcare participants. It's doing things differently. And I think you're going to have a discussion about this later today or tomorrow. We had to figure out what we're going to do for paying people. This isn't all of a sudden insignificant, like an afternoon where they sort of come and give us comments. These people are doing serious work. So we had to figure out a payment model and a business model for this, and it wasn't trivial. And we need then also ways to make this fundable and sustainable. Those are real challenges. Myths, engaging patients isn't easy. Not everybody is super keen to do this, and some people don't want to be engaged. That's okay, but they don't. And you also have to deal with the problem, and I had to do this, is that everybody in your team thinks this is a great idea. And, you're enthusiastic, or I was enthusiastic, and some people are like, really? And how are we going to do that? Well, really? Or particularly qualitative research colleagues of mine who've spent their entire career doing qualitative research, having a patient coming in and doing the research. A little bit of some issues there. So interesting. So that's the dynamic we've been dealing with. So very happy to have questions and discussion, and I know we have lunch too, so happy to chat there too, and that's my contact, so thank you.
I walked all the way up here. There has to be a question.
Oh, there we are. She was a plant. She's from Alberta. Yeah, I'm joking.
So thank you so much for that talk. That's a very enlightening talk, and certainly being from Alberta, our respirology division is engaged in the strategic network, and so our division is tasked with coming up with indicators, quality indicators for across the pulmonary clinics, not just for CF. But of course, CF is what we know, and I'd be curious if you can expand a little bit on the patient payment side of things, because the challenges that we have in our population is that patients spend many hours a day just doing their treatments, and then this is an expensive disease, and then they have to hold jobs or they're going to school full time, and so the patients that end up in your population, in your OA population, for example, the patients that end up getting engaged and being these patient leaders, researchers, do you find a phenomenon of being self-selecting patients who are higher socioeconomic status, or conversely, the ones that need that money and therefore they do this, and then would that be a risk of biasing your results because the patients that participate are usually the disgruntled patients or patients who have the luxury of time?
Do you want to take that first?
I'll start first. When Deb was talking about payments, she's more talking about the payments of the PACER researchers as patients. A large amount of our research, even though we're taking a long time, we're not providing them other than lunch and transportation fees. We're not providing them. We did find that our Indigenous population really expect a gift as part of their culture. So we were just giving them small gift cards, and that was fine. the part Deb's mostly talking about it in engaging is the patient researchers, the funding for that.
Yeah, it's a great question. So in the training, there is no reimbursement. So yes, there is a selection bias, and we've had this question multiple times. And I'm not sure that you can completely eliminate a selection bias, because just like you're sitting here, well, you're a selected group of people because you're interested in this, right? So you can't make people do things they don't want to do. So there's a natural selection bias, but it's important to be aware of that, because you're right. We do, if you looked at a population basis, have, a bias in terms of higher socioeconomic status. Having said that, we do work very hard to try and get some representation. Interestingly enough, even in our very first OA cohort, we had a homeless person, for example. Like, we had to find a computer. I lent them one of ours, actually, because they didn't have it. But they wanted to be involved because we had posted and recruited from everywhere. So we do have some representation, and we work really hard to try and have, different groups and reach out. I know Esther's been involved heavily in the mental health population, which is a really hard population to reach out to for, as you can guess, many reasons. So we try to do that. But once they've graduated and they're part of the PACER program, there is the idea that now they're working as researchers, and there should be a reimbursement for that time because it's significant time. So they're past the graduation. So I think it's going to be talked about later, but CIHR has also put in place a policy for the SPORE networks for reimbursement. And most provinces now, through their SPORE units, have a policy. Anyway, there are details of that, but I think you have a whole session on that. So there is a policy for reimbursement.
Yeah, hi, Martha McKinney from Université de Montréal. So what are the advantages and disadvantages of having somebody working as a patient researcher in their own disease area versus having, for example, someone with CF working in a study on bowel disease? You have is the experience of being a patient or somebody with a chronic health condition enough to give you that? And are there biases to working with other people with your own disease versus having the experience of a patient, but then applying that to working as a researcher with patients with other health conditions?
Sure, I'll go. So that's a really great question. I think people from the outside thought, well, only if we were looking for experts, we need an expert patient to come in. Basically, the ability to listen and empathize and let patients talk. One of the hardest things you have to teach students is to get them to shut up. You teach the focus group person sits and is one of the people. You want crosstalk. You want a lot of things that you don't normally have. You want to become invisible, and you want these big conversations that go back and forth. So you don't need to have the disease to understand the disease. You have to be able to listen.
Yeah, so I guess my view on that is I do think, so certainly there are things that are transferable. Because you're right, these are skill sets in terms of how to do qualitative research. And I guess one of the things that I've learned in working with PACERs is patients tell patients different things than they tell me. And there's a relationship, a rapport that's immediately established if you have a common ground. So I think some of those skills are absolutely transferable, chronic disease. But I also think, I really do think there is some advantage because every disease has its details and its nuances that even if you have another chronic disease, you don't understand that. So I think the relationship and the ability to relate is higher if you're working with people who have the same disease, talking to people having at least similar disease. So I don't know what the right gradation of that is. So for example, in Imagine, well, we have IBD, IBS, ulcerative colitis, Crohn's. Well, are all of those close enough? You know, so it's hard. I don't know where the gradation is, but I do think the closer you can get, probably the more bonding relationship there will be. And at the same time, the patient researcher, as a patient researcher, is there to listen to those other patients. But it's the rapport, I think, that matters.
I had just
Yeah.
one other comment. One of the studies I have that hasn't been published yet is, I called it the Goldilocks Effect. It was around mental health. People who had mental health but are working, they've been at least 10 years out. One of the things they told us is that they had to be well enough but not too well, because sometimes they lost services. So, and I think this same thing happens in other medical. So one person was getting an extra amount of funding for transportation. It was only $61, but they were like, you know, you're doing well, you've got this job, blah, blah, blah. So she just started crying, and they're like, okay, you get your $61 a month. And sometimes to get certain types of counseling, you have to be so well. So they realized they were presenting a little not as well. So it's this thing as a patient where you're not getting the real voice of your provider, because you've got some criterias that maybe say, we take this patient and not this patient. So sometimes the patient has to adapt to be the type of patient that you will take. And that was one of the findings in one of our studies. Can't be too well, can't be too sick. Just right.
Hi, I'm Leona Pinsky. I'm on the board of directors of CF Canada, and I have a 20-year-old with CF. And just so that there's a patient and family voice here, I have a couple of comments. When my daughter was younger, I was very involved in the parent advisory at our children's hospital, and it was very frustrating to often be the only person at the table who wasn't being paid. Yeah. And there'd be all these meetings, and they gave me my parking. And, you know, in my situation, it was fine, but I knew a number of other parents who just couldn't participate because, you know, and everyone else at the table is being paid. So you're really not saying you value that information. If it's about value, right? So one of the reasons I stopped being involved is it started as patient and family-centered care became more the norm. It started to feel more like a box people were checking. Yeah. And it became it became very family-focused. And I'll give an example that's from Cystic Fibrosis Canada, and so as a board director, I bear just as much responsibility for it as any of you, so it's not a criticism. When we have our accreditation site visits, we ask the clinic to choose some families to come in and talk about issues with the clinic. Well, you know, there's a pretty big bias right there about who's going to come in and talk. And sometimes I think the people we need to have around the table are the ones who are the most unhappy. And the ones who will speak the most candidly, which isn't always the most popular thing. And then another thing that really resonated with me is you talked about what's most important to patients and families is not what's most important to clinics. So one of the most exciting things for my daughter, the most exciting thing moving between pediatrics and adult clinic, was they did the PFT in the room, and that meant she was there 45 minutes less, finished. And we'd been trying to get PFTs done in the room in the pediatric setting for years, but it you know, for a number of reasons, it wasn't a high enough priority. So those were my comments. Thanks.
I can just make a comment with that. So Alberta is trying to look at paying patients because we have the same thing on these strategic networks, and money is value. So if the patient or family member is not getting paid and everybody else at the table is getting paid, what are you saying to the group? This person is not as valuable as everybody else at the table.
All right. Thank you. Thank you.